I'm just going to talk about the decision making in pelvic ring disruption. And till the technology works, we are going to discuss some points. The pelvic ring disruption is a severe injury, and we all know from the last distinguished two speakers about the magnitude of the trauma, the magnitude of the bleeding, of the fracture, and it is a life-threatening situation. And the decision making, when you see the patient, you think about few things. The early management. I'm sorry, I need to give my password. Sorry about this. That's usually failure of technology. Pelvic ring disruption. We usually think about pelvic ring disruption it underscores the importance of the anatomic relationship and the associated injuries. And you usually would think that when you have a bad pelvic injury or bad pelvic fracture, usually it is associated with a very bad soft tissue injuries. And it is a marker of the severe injury of the body. The overall mortality is about 60 to 10%, which is very high, and it is life-threatening, as you have said. The magnitude of the force is quite high. As we can see here, the ACL injury will need about 500 to 1,000 Newton to produce ACL injury, while in lateral compression type 1 pelvic injury, you need about 6,000 to 9,000 Newton to produce the pelvic fracture, which is a high force. The associated injuries, a lot. Hemorrhage definitely is a chief one. You can have up to 75% of pelvic fractures associated with injuries. Either it's a small injury, massive injury, urological injuries about 12%, neurological injuries about 8%, gynecological, thoracic aorta, ruptured diaphragm, rectal injuries. A lot of soft tissues can be injured during pelvic ring disruption. The learning outcomes from this talk is to identify the decision-making process for pelvic ring injuries, to list the priorities of management, and to plan for the fracture treatment. The decision-making will be built on patient assessment, soft tissue assessment, neurological assessment, and the fracture assessment. Patient assessment. We see first the hemodynamical stability of the patient. Is it stable? Is it unstable? Polytrauma, age? We go through the ATLS according guidelines, which will see the airway, breathing, circulation. And when we come to the circulation, either we have a stable patient or unstable patient. If the patient is stable, we go further to disability and we carry on for treatment. If the patient is unstable, we should know why and what to do for that patient. Hemodynamically unstable patient, the source of bleeding might be an open wound, might be hemothorax, hemoabdomen, long bone fractures, like bilateral femoral fractures or something like this, or the pelvic fractures. The pelvic radiology in ATLS, according to the guidelines, AP of the pelvis should be done in all polytrauma patients. Actually, the ATLS guidelines says that you should do 2 X-rays as a primary survey, which is the AP of the pelvis and chest X-ray, because you can detect massive injuries from these only 2 X-rays. The AP pelvis should be adequate. So we can see both iliac crest, both femora, both acetabuli, both sacroiliac joints. And you can get about 90% of posterior instability from only an AP X-ray of the pelvis. Hemorrhage is the cause of death. Because we have got a retroperitoneal space which can accommodate up to 6 liters of blood. So we need to address this problem. 3 sources: arterial, venous, and osseous. And we know it is a life-threatening. The life-threatening hemorrhage is commonly coming from the venous side because lack of the muscular wall which will contract to stop bleeding. The polytrauma patient, we have a patient, we should see if it's stable, unstable, borderline, damage control versus total care, fracture stabilization. We should think about all of this. Age of the patient, because the age of the patient actually, it plays a role in the treatment of the fracture pelvis, whether pediatric or geriatric. Usually, young individuals, they withstand massive trauma better than the old generations. The pregnant lady, usually it is an issue if you have got a massive pelvic disruption in a pregnant lady. And usually this comes to the high fetal mortality and the high risk for the mother herself. Soft tissue assessment. We see for perineal ecchymosis, skin, we should carefully inspect skin for open fractures. Perineal tears, the mortality rate are significantly high in perineal tears. And we should do early aggressive resuscitation is essential actually to survive the patient. And the recommendation for perineal tear, initial debridement, early antibiotic, tranexamic acid administration, immediate fecal diversion, and the early parenteral feeding. You should do this early. Open pelvic fracture, high mortality rate. It's more than 50% mortality rate with the open pelvic fracture, which is very high. And we should do resuscitation, aggressive debridement, cystostomy, colostomy, plan the reconstructive procedure later on. We should identify the associated injuries. And the associated injuries usually either from blunt trauma versus bony spikes. You can have a blunt trauma to the viscera inside the pelvis, or you can have a bony spike which is penetrating one of the organs of the pelvis. And usually these are bladder, rectum, vagina, and you see for imaging of pelvis organ, you might do ureterogram or ascending cystogram. Clinical examination is important for the case coming in the ER. You see for the vaginal examination to see open fracture, bleeding per vagina, lower limb pulses, lower limb neurological examination to see the strength and the sensation, because the associated neurological injuries with the pelvic ring disruption, they are high. It's about 12%. Rectal examination. It is mandatory to do rectal examination in the ER for the polytrauma patient. You can see the sensation of the sphincters, and you can see the position and consistency of the prostate, which is very important. If you do PR and you see the process is high riding up, it's contraindicated to put a catheter because you know that the urethra is avulsed. And you see presacral hematoma, and you see mucosal penetration from the bony spicules, but you should beware when you do the examination, because you might tear your finger or you injure your finger putting your finger inside the rectum. If the rectum is violated, you should do diverting colostomy, because you should divert the fecal material from the wound. Male, you should examine the scrotum and the penis carefully. You might see a meatal hematoma or bleeding their penis, and this indicates urethral or bladder injury. You see scrotal hematoma, high riding prostate for male, blood on the venous meatus, inability to void. The patient sometimes is saying that I need to void, but he cannot void. Gross hematuria, and even sometimes when the patient does not feel that he wants to void, this might be an early sign of rupture of the bladder, because if the bladder rupture, so the tension inside the bladder is gone. Does this patient need a Foley catheter? No, definitely, because he has a massive scrotal hematoma, and this might indicate urethral injury. Close or internal degloving injuries, which we call Morel-Laval lesion. You might see it, which is a separation between the subcutaneous and the fascia. All of these are indications of severe injury. Fracture assessment. Fracture assessment, you should see the pathoanatomy, stability, and early or delayed fracture. Identify the high-risk pelvic disruption. We should think about this. When we see the patient, we should identify the high risk of pelvic disruption. And this high risk of pelvic disruption, we can see it from radiology and examination. And by radiology, you just do first the AB X-ray, as we said, as an ATLS series, and then we proceed by this. Physical examination, to see the high-risk patient is usually poor sensitivity. It's about 8%. To identify from clinical examination, it is a high-risk patient. And when we say clinical examination, by examining the valves itself, not by examining the ATLS guidelines, which is the circulation and this thing, but by examining the valves itself to see this is a high risk and this is not the high risk, this is poor sensitivity. The radiograph or the radiography. We do anteroposterior AB, inlet, outlet, and CT. The AB, as we said before, it should be adequate. The inlet view, as being said before, I'm not going to go for the details, will show us the pelvic ring and the horizontal penial rotation, posterior displacement, and the ala of the sacrum. The outlet view, which is a 90 degrees perpendicular to the inlet view, you can see the vertical displacement or cephalic displacement, the sacrum and sacral foramina. CT definitely is going to show the posterior displacement and the posterior fracture quite nicely. And you can add the 3D CT by reconstruction, which will show the displacement nicely. The radiographic signs of instability, as you have seen here before, sacroiliac displacement more than 5 millimeters in any place. So in any place. Posterior gap, avulsion of the fifth lumbar vertebrae, and then we go for the classification. To treat a case of pelvic fracture, you should know the classification. I'm not going to go into details because you have heard that, but the classification should aid in predicting hemodynamic instability. It aids in predicting visceral injuries. It aids in predicting pelvic instability. It aids in understanding the mechanism of injury, force, vector of the injury, and surgical tactic for reduction. And as you have heard before, the classification system are anatomical Letourneur, stability and deformity, vector force like Young and Burgess, and the AO. The anatomical is a Letourneur, it looks for the pelvic breaks. And then it shows the anterior and the posterior breaks. Young and Burgess, which is a common classification being used based on the mechanism of injury. And it is divided into lateral compression, AB compression, vertical shear, and combined injury. Lateral compression, when you have the force from the side, and you can, it is subdivided into type 1, type 2, type 3, and definitely by going to type 3, which is the windsweep pelvis, which is unstable pelvis. You have a break here, and the contralateral side is open from the force. The AP compression, which is subdivided as well, the type 1, type 2, type 3, type 2, which is the open book with intact posterior sacroiliac ligament, type 3, which is a break in the front and completely disrupted sacroiliac joint, front and back, which is highly unstable type of injury. Vertical shear, when the force is applied to one leg before the others, and this might disrupt the pelvis on one side, and the other one is intact, and it is highly unstable type of fracture. Type classification, which is divided into type A, type B, type C, and we need to know that type A is usually a stable type of injury, type B, which is partially stable, incomplete disruption at the posterior arch, type C, which is the ring is completely unstable with complete disruption at the posterior of the arch. Treatment plan according to the fracture stability, we think about type A, operation is rarely needed because it is a stable type. Type B, we need anterior stabilization because the posteriorly is incompletely unstable. You still have got posterior ligaments at the SI joint. Type C, you need stabilization of the entire ring. We should think about this. The non-operative indication is type A. As we said, it is a stable type of the pelvic ring injury. You don't need any stabilization. You just, and you see that the displacement is less than 1.5 centimeter in the front. It doesn't need any active treatment. Type B, it is an open book injury when you have a gap between over 2.5 centimeter, and definitely type C is a completely tied type C, completely disrupted pelvic ring. The SI joint is completely disrupted front and back, and this is in need of stabilization. It is a multiplanar anterior ring stabilization in type B injury. You need to put either external fixator, symphyseal plate, or pubic ramus fixation. And the pubic ramus fixation usually is rarely needed on its own, but you might do it if the distraction is quite big, or there is impingement on the vaginal vault or bladder or even the rectum. Posterior stabilization, you need to do posterior ring stabilization in type C, and you do SI joint. When you see SI joint dislocation, you might put anterior plate or iliosacral screw. Sacral fractures, you might put a tension band plate. SI joint fracture dislocation, you might put plate fixation or lag screw. Posterior ring stabilization, as we said, fixation technique, you might put an SI plate, posterior plate, iliosacral screws, transiliac rod, or spinopelvic fixation. And you will hear a talk about this. Neurological assessment, you might do neurological assessment to see the lumbosacral injuries, sciatic nerve palsy, sacral root injuries, and this definitely, as you can see here, if the fracture is lateral to the foramen, you might have 6% injury. If through the foramen, it goes up to 28% injury, neurological. And if it is medial to the foramen, it might be 57%. You might have injury of the nerves. It is the most significant influence on the outcome is the neurological injury. Because at the end, if you survive the patient, if the pelvis heals, but if the patient has got a permanent neurological deficit, definitely he will have disability. Controversy about decompression and fixation definitely should be put into your plans. Conclusion, decision making. Pelvic ring disruption is an indicator of a major surgery. It is potentially life-threatening injury. And you plan your management to reduce mortality and morbidity. And the assessment of the patient will save the patient life. Associated injuries, if you assess it quite nicely, you reduce morbidity. And the assessment of the fracture will help you in fracture treatment. Generally, type A, it needs non-operative treatment. Type B, operative treatment with the anterior ring fixation. Type C, operative treatment with anterior and posterior ring fixation. Thank you.
Thank you very much, Professor Khalid. Next speaker.